This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2014, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Analysis of Radial Artery Catheter Placement by Respiratory Therapists Using Ultrasound Guidance. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Mr. Bill Malley. Mr. Malley is a registered respiratory therapist, certified pulmonary function technologist, and a fellow of the AARC. He was the program director for the BS program at Indiana University of Pennsylvania, West Penn Hospital for 25 years, as well as an administrative director for 15 years. He is also the author of a textbook focused solely on blood gases. Neither Bill nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Bill, welcome to the program.
Thank you, Shauna. Well, I didn't respond to the sunny question, but it's pretty much never sunny in Pittsburgh, so but I'd like to welcome everyone and wish them happy holidays as we do our December JournalCast. This article, again, titled Analysis of Radial Artery Catheter Placement by Respiratory Therapists Using Ultrasound Guidance. A little background on the arterial lines, which many of you are aware. Arterial lines are typically inserted in the emergency room or critical care areas to, one, directly monitor blood pressure, and it's actually a more accurate measure of blood pressure in real time. Most often, I believe, to facilitate immediate acquisition of serial arterial blood gases when we know we're going to be doing blood gases for some period of time. And number three, to facilitate immediate acquisition of other blood studies as well. So the arterial line has, in some cases, we try to avoid, in all cases, in fact, invasive catheters, but in certain situations they are unavoidable. And we're going to talk about the practice of inserting those catheters today. The other thing, of course, that an arterial line will do is that it prevents the potentially painful and uncomfortable arterial punctures, which may be associated with nerve or vascular damage. And the sampling from an arterial line, generally you will get a better sample, less inclined to have errors or factors that may contaminate your blood gas, such as inadvertent venous sampling or admixture. Arterial lines, as we said, we do try to avoid them. Potential infections, vascular complications can occur, and there can be some discomfort and pain during catheterization. The radial artery, which I'm sure you all know, is the vessel of choice. The reason for this is that it is relatively superficial and accessible in most patients. It is not particularly close to a nerve, and most importantly, as we all know, there is collateral circulation in most all people through the ulnar circulation. So if there would happen to be some damage to the vessel, we could see that there is an alternative route for the blood to reach the hand. Okay. This particular study, is focused on the optimal technique for inserting arterial catheters. I don't know, that actually might be a question I hadn't originally planned on asking, but it has been my experience in most hospitals that the respiratory therapists do not insert arterial lines, but I know they do down at Duke Medical University, and I think this is very good for our scope of practice and shows confidence and development enhancement of our profession. But at any rate, we're looking for the best way to do this, and in those patients whom it has been deemed medically desirable and necessary, of course always requiring a physician's order. The research question is basically, in this particular article, can respiratory therapists performing arterial catheterization use ultrasound guidance to perform the procedure more effectively? There have been studies, as I will show you in the presentation, and most of those have been done by physicians, and there has been improvement in access of the arterial line, the number of attempts, etc. And we wanted to see if this was indeed also true of respiratory therapists through this particular study. Is this research relevant? It is certainly relevant, and as I studied it in more detail, I felt that it became even more relevant to me because not this particular study, but there are randomized controls, clinical trials that have demonstrated a clear benefit to using ultrasound-guided radial artery line insertion. All right. So it is a relative it is an important thing to look at, and it certainly is relevant to our profession. Overall success with ultrasound guidance. Kind of the background before they did their study at Duke is in one of the studies that I believe was a narrative review, the summarized result of 3 randomized controlled studies concluded that if you use ultrasound guidance, you had fewer attempts at successfully inserting the arterial line, and also less time for successful catheter placement. And all of those things likely are better for the patient and lead to decreased complications and more optimal care. The research is also relevant because it has never been done by many other professionals. I did see anesthesiologists, cardiologists, but the use of respiratory therapists to perform radial line placements, especially in those places where they're already doing this procedure, such as Duke, with this adjunct of ultrasound guidance improve the procedure, the effectiveness of the procedure. And it's good for, obviously, our scope of practice, and may potentially produce cost savings as well in having respiratory therapists perform these types of procedures. This picture is it's in the article in the December issue, and it shows an arterial line being inserted with ultrasound guidance. And if you look up on the ultrasound, it isn't real clear. On the next slide, I have a little bit larger picture. But the red arrow corresponds to the radial artery, and the white arrow corresponds to the path of the needle as it approaches the artery. So, in fact, we can see exactly what we're doing. And this makes the procedure much more safe than just simply palpation and thinking that we, have the right location of the artery, etc. So it's kind of neat to be able to do this in this way. In the next slide, I blew the picture up a little bit larger, which you can't. It's a little bit distorted. But again, you can see that it's not real clear again, but you can see the red arrow pointing to the artery and the white arrow showing the catheter moving in towards that artery. So kind of neat stuff, if you will. Regarding Duke Medical University in this particular study, I did not see any conflict of interest. The authors disclosed no conflict of interest. There was some support from the department funding of Duke Medical University, and as I had said previously, it's a well-known institution for quality research, particularly in the field of respiratory care. They did ask for and receive IRB, Institutional Review Board approval, to review the recorded data of these patients. All right, what did they do? Well, they looked back. In fact, it was a retrospective analysis of consecutive patients from December 2008 until October 2011, which is almost 3 years, 35 months, in whom radial artery placement using ultrasound guidance was initiated and attempted by some respiratory therapists, as we'll describe, at Duke Medical University. So they began trying this procedure in December 2008, and the data goes until October 2011. 10 respiratory therapists participated in the study. There was a wide range of experience in placing radial artery catheters. It was my assumption that they had all, well, yes, according to this data, been placing radial artery catheters, some for only 2 years, but some for as many as 30 years in this regard. The respiratory therapists underwent a training program in the use of ultrasound to facilitate radial artery placement, so they didn't do this just in the blind. Training, we know, of course, is important, and training in respiratory care is always very important. The training program consisted of understanding the ultrasound equipment, being able to identify the radial artery via ultrasonography, demonstrations of some of the different techniques of ultrasonography transverse, evaluation, longitudinal evaluation, different ways that you can look at the artery. Proper sterilization technique was part of the training program, and proper hand technique to prevent the probe, the ultrasound probe, from moving during the line placement, which would also be a factor. So there is particularly some skill involved in this, and the training period, it wasn't clear how long the training period was to me, but these are the things that were included in the training. Certainly, if you were to institute this procedure at your institution, you would want to have a good training program. And there was actually one of the studies that I looked at showed that there was a relatively steep curve as people, the first couple, after training, they didn't do that well, but shortly thereafter, they became quite expert with the use of ultrasound in guiding the radial artery catheter placement. Participation, this is probably a little bit of a weakness of the study, but the decision to use ultrasound guidance was at the discretion of the therapist attempting the line placement. For example, the physician would order placement of an arterial line, and the therapist would use the ultrasound guidance if they felt, if they felt it was necessary, I guess. And in fact, the data kind of showed that typically when they would use it most often would be when the patient had a weak or absent pulse and they were trying to insert an arterial line. So, you know, ideally in a prospective study, one patient would get the ultrasound guidance, the next one would not, and it wouldn't matter. Some of those factors would not matter. All data were also recorded by the respiratory therapist performing the catheterization attempt. So that is how they put together the data on the patients who you know, received ultrasound guidance. They compared that, on the other hand, they didn't have a true control group due to the nature of the study and the retrospective nature. They compared it to the success rate throughout the institution for all other respiratory therapists who were doing arterial catheterization without the use of ultrasound guidance. And they chose the year 2011, and that was calculated. Remember that the research group spanned over December 2008 to October 2011, so it wasn't exactly the same time period, but a relatively close time period for purposes of this study and what they were able to do. The results, they had 122 ultrasound-guided radial artery catheter attempts that were done by respiratory therapists and reported during that period, that 35-month period. Actually, it could have been a study pretty much based in the emergency department, since 121 of those were done in the emergency department and only one was done in critical care in the ICU. The success rate, overall success rate, meaning did they get the catheter placed in the patient, of the study group versus the comparison group that I just described. The study group, 105 out of 122, or 86.1%, were able to insert the catheter. In contrast, in the comparison group, which were all the other catheters inserted by respiratory therapists during 2011, 624 were successful out of 802, which is a significantly lower number, so that the cases that used ultrasound tended to be more successful in getting the catheter placed. And if indeed the therapists were choosing patients who were had a weak pulse or an absent pulse in some cases, that was very, very positive, very remarkable results, because they were probably doing a somewhat more difficult population in that regard. The p-value, and by the way, the p-value is always, was this study significant? I just wanted to point out that the p-value really evaluates the null hypothesis. The null hypothesis says that it doesn't make any difference in the two groups, whether you use ultrasound or whether you don't. It shouldn't make any difference. And so it's a measurement of the likelihood of the null hypothesis. So a very low p-value, although it means there's probably a difference in doing it one way versus another, but it could be some other variable. It doesn't directly measure the thing that you're looking at. It's just saying that this is unlikely to have happened by chance alone. The first attempt, which is different from the overall success rate. These are, again, the people who, on very first attempt, they were able to place the catheter utilizing ultrasound. 77 of the 122 were successful, or 63.1%, and that's a very good number from the research that's out there. They didn't really have a comparison at Duke University for that, so they pulled results from a study, that narrative review study that had been done. And this is pretty much what I had read in most studies. Historically, the success rate on first attempt is quite low, around 43%. So that would be a very significant improvement. Again, not a clear-cut apples to apples, but nonetheless a very substantial improvement in the percentage of people who we only had to attempt one time. And that's certainly beneficial in many ways, as we talked about earlier. They also, as secondary results, and in the article, if you haven't read the article, or if you have read the article, you can look at Table 1. They also looked at the age of the patients, the gender, since females may have slightly smaller diameter vessels, and the blood pressure of the patients, and they put that in the table to see if there was any difference in using the ultrasound that was a particular advantage in any group, and they did not find any difference. If you notice all the high P values, it means that the null hypothesis is likely that it did not make difference whether the patient was male or female, hypotensive or not, or elderly. They did have, with the elderly, there were some patients that they did not have the age, so that was not included. They don't have the full 122 under the N population there. They also had another table in there that looked at differences in success rates based on subjective pulse strength and systolic blood pressure. That table, radial artery cannulation success using ultrasound guidance by RTs based on subjective pulse and systolic blood pressure. Again, they did not notice any difference in the various groups. So there were two purposes, in a sense, to the study. The primary outcomes were they able to improve the results on first attempt, improve the overall results, and then as kind of a secondary thing, they looked at some of these other, were there any factors that might predict that? And they really did not find any secondary issues of relevance. The null hypothesis seemed consistent, no significant differences in the various groups. P-values were always greater than 0.05 in these groups. There were a couple of interesting findings that in a way were very interesting. In subjects with initial unsuccessful cannulation, the ultimate success rate was almost identical to subjects with successful initial attempts. Now I had to think a little bit about what that really means, but regardless of the reason why they were unable to cannulate the patient or catheterize the patient on the first attempt, they were equally likely, as if this was a totally new patient, when they tried the second attempt. So that that was very interesting that those numbers just coincidentally turned out to be almost identical. And there might be more to that. I could not really totally make sense out of it, other than the fact that you were equally successful in the second attempt as the first attempt. One would think that if you couldn't get it in the first attempt, you would be less likely to get it in the second attempt. What I also found was an interesting, notable finding was that in 3 subjects with no detectable blood pressure, catheters were still successfully placed in 2 of those. So I thought that was quite remarkable. I don't know how often that happens, but without blood pressure, one would think it would certainly be much more difficult to insert an arterial catheter, yet they were able to do so using the ultrasound in 2 out of 3 patients. Discussion. The study suggests there is a benefit in overall success rate when trained respiratory therapists use ultrasound-guided radial artery catheterization. So that is what this study, I believe, found. And the study was more of an initial experience, a report of an initial experience using respiratory therapists. Would the same thing happen that had been happening in some of the other studies? And were we moving along with the wave of the future, perhaps? In similar research, I did find one article that had, again, an even higher success rate, but it was ultrasound-guided radial artery access by non-ultrasound-trained interventional cardiologists improved the first-time success rate and shortened time for radial artery cannulation, meaning that interventional cardiologists who were really not too knowledgeable about ultrasound. After a short work with ultrasound, some sort of short training, they were very successful, and it enhanced their results as well. And these were people, these cardiologists were relatively inexperienced, they said, at inserting arterial lines. There were only 50 patients in this particular study, but it was remarkable that 80% of those patients actually were able to achieve successful cannulation on the first attempt. This particular slide, if you look down the bottom, is the first attempt. Second attempt fell to 12, and actually it fell, again, 6 and 2%, and the remainder of the patients were cannulated. But it showed that they were just a little bit better, but I thought it was a good graph to show the benefit of the ultrasound guidance in that group as well. This article was also the editor's choice in the December issue, and that's why we're presenting it. There is a very interesting editorial in the December issue written by Dr. Benedict regarding, the fact, the title of her article, if I just look at that, "Are We Beyond Cowboy Tactics for Arterial Catheterization?" She somewhat makes the point that, a lot of people kind of tend to stick to the old way of doing things, and that there's pretty solid evidence out there that ultrasound guidance helps, and that we should abandon, not be afraid to jump right in and start using that. And she has a photo that I was unable to put here, but it's in the Respiratory Care Journal that you might want to look at, that shows a massive hematoma in an 80-year-old patient in trying to insert an arterial line, and making the argument that had ultrasound been used in the first place, this very likely would not have happened. So it is kind of a dramatic picture if you look at it. Unfortunately, I was not able to get that, but she did have some good literature, meta-analysis on this subject of ultrasound guidance of radial artery catheters. And the meta-analysis, the most recent one that was done, as you can see, it was done in the year 2014, published in Critical Care Medicine. They showed that there was increased first attempt success with ultrasound guidance. 2, there were reduced mean attempts to access with ultrasound guidance, meaning there were fewer attempts overall until we were able to get the catheter in, and that this was one of the places where they showed that there was actually, according to the literature and the meta-analysis, that there was a lower risk of hematoma. Hematoma not being a huge factor, but if you see the hematoma that was characterized, that was shown in the patient in the editorial, you could see that we would certainly like to avoid that from happening, if at all possible. She also talked about the International Consensus Conference on Ultrasound Vascular Access, and that there was a very high evidence level that ultrasound-guided arterial catheterization improves first pass success and should be used routinely in adults. So that I think she makes a pretty good argument. I don't always agree with the old, although I thought in the old days, respiratory therapists, we certainly were cowboys and took a lot of pride in jerry-rigging and making something happen. But I think we've kind of grown beyond that and the anecdotal experience, and really do look at the data and the literature, and certainly our journal is evidence of that. But it does seem to make sense that we should be using ultrasound guidance routinely when we insert arterial catheterization catheters. It was interesting to me, as a person who really is more familiar with arterial punctures, there was one study done, and it's actually, I believe, listed in the article. I don't know if I have the citation right at hand here, but there was one study done that looked at the success rate of doing arterial punctures, just doing a simple blood gas under ultrasound guidance. And the study actually was a negative study from the standpoint that it just seemed as though we're no more successful and that it took more time. And that would be something that may happen in the future. I don't know, 10 years down the road, if we might be looking at routine arterial punctures, since again we can see inside what we are doing rather than going by our palpation, which can be very variable in the therapist, etc. So there currently is no evidence that it would be beneficial in arterial punctures. In fact, there is some negative evidence, but it wasn't really that strong, and that would be a subject that should be further studied before we reach any conclusions. Some of the limitations that they cited as well of the particular study at Duke, they listed as a limitation that they did not systematically record the ultrasonic technique that was used, transverse or longitudinal, etc., the patient's body habitus, or the indication for placement. So more detail on how they use the ultrasound, number one, and number two, on the patients, more information about the patients and why we were putting arterial lines. Certainly you can, there would probably be those people out there who would be against any arterial line placements, and certainly we've decreased the number that we place. I know there have been studies that shown we do a lot more blood gases when we have an arterial line in place than we would otherwise, and are those blood gases really needed? They also said that, when they looked at those secondary factors such as pulse strength, obviously that's a subjective indicator and a limitation of the study. To me, probably the strongest limitation or criticism of the study would be the decision to use ultrasound being determined by the respiratory therapist performing the procedure. As I said, they tended to use it more often in patients with weak or absent pulse. Obviously, respiratory therapists vary in motivation, experience, and even in this training, you could look at any of those factors. What would make a respiratory therapist do that? There were only 10 that were trained to do it, and it was really at their discretion. Respiratory therapists also recorded the data, and the study did not have a true control group. again, it was really more a report of an initial experience rather than a multi-institutional randomized prospective study, but it did concur with the findings of the more sophisticated studies as well. The comparison groups, as I said, did differ slightly from the study groups. The primary conclusion that I took from this, the initial report, which looked at RTs and their results, demonstrated that they generally achieved similar pattern results to the randomized meta-analysis. In other words, they had improvement, both in initial attempts and also in overall success rates. They didn't really show decreased complications, which has been shown in the meta-analysis, but basically the results were very consistent with that, in that the respiratory therapist doing it did not change anything as well, and there's obviously benefits to having the respiratory therapist do that. Take-home message to me, and based on the recommendation and the strong evidence that I was unaware of, appears to be that ultrasound guidance should become, frankly, the standard of practice for radial artery catheterization. They stated in their article that ultrasound guidance is already the standard of care in the placement of central venous catheters. So it's probably moving in that direction as well. So that really concludes. We can open up to discussion. I say this often about lectures and research, but a research article often makes you feel dumb at one end and numb at the other. Hopefully it wasn't that experience entirely for you here today. I always remember Dr. Dave Pearson when I think of a lot of these research lectures and research presentations. He said to research is for the purpose to improve, not to prove. And there's always that bias. I know we used to do research studies with our students, and they would always tend to come in with ideas on evaluating that the respiratory therapist could do XYZ better than some other group, or than nursing, or than the physicians. And you always need to be careful with that. We want to improve the way we care for these patients, and certainly respiratory therapists are a part of that. But he was so committed and so excited and happy that we achieved Index Medicus when he was editor of the journal. I thought that was, I just saw the beam in his eye, if you will, that we were now a peer-reviewed journal that would be cited in Index Medicus. And that certainly brought a lot of credibility and pride to our profession. And I think it's a good idea to do these research presentations for students to look at, analyze studies, understand at least the terminology, and be a good, if not researcher themselves, at least be a good consumer of research. And again, another quote, I like a few quotes to end on, but research, like education, is not filling a bucket. It's not just always more information. Hopefully it lights a fire for some of you to do some research on basic things that you do at your institution. In your daily routine, you can come up with a lot of good research ideas, both students and practitioners alike. And it's very important that our profession goes on with research. I always there was a graph that I did not include about successful people. I know it was in the book, 7 Habits of Highly Successful People, but it said what the most important things we do in our life are not the urgent and important things, but the important things that are not urgent, and that we need to set aside some time to write that paper, to do those things, to research that study, to develop in our careers and make a contribution to our profession and our patients, and hopefully inspire someone in our profession. So that concludes my presentation, and I will see if there are any questions that I'm able to answer.
Thank you very much, Bill. This was a really, really informative session. The article, if y'all haven't read it yet, the manuscript is very well done, and it is very interesting to read that in conjunction with the editorial by Dr. Benedict. So, Bill, we do have a few questions, but before I get started, one of the participants actually wanted to know how many of the therapists around the country are doing art lines. And I don't know, obviously I doubt our group here is representative, but if you do art lines in your facility, give us a green check mark from that check mark box, and tell us how many folks. And if you're not, you can give us a red X to indicate that you don't do that at your facility. It's interesting to see what facilities are capable of, or their therapists are allowed to do the art lines versus not. So thanks. Keep those votes coming. We're going to transition to a next question. So
that's very good.
So one of the first questions that we got was wondering about the vascular complications associated with the insertion of an art line. Do you know offhand what the incidence of those vascular complications might be?
I do not. I think I have some of that data in my, when I had written that section of my textbook, but I know infection and some of those issues are more of a concern when you have that, constant open environment. But the vascular complications, my honest answer is I do not know. I suspect that's been studied, and perhaps I've even quoted it in my text, but I can't remember offhand the incidence of vascular complications. I do not remember. I know I've read articles about isolated, rare, but situations where there's been serious vascular and nerve damage with punctures. I do not recall, even in a case study, where there was, a serious long-term vascular complication. There may be arteriospasm, some clotting, some minimal obstruction afterwards, and of course hematoma, but some of those types of things.
Okay, so we did our little poll, our informal poll, and it looks like about 68% of us didn't vote, but I got a few comments over here in the chat box. It looks like the majority of the therapists who voted don't have the ability or the clearance or the training or what have you, specific situation for inserting art lines in that facility. So that leads us into the next question. Even though it's identified in as part of the scope of practice, and our therapists aren't doing this, we've identified that this is a potentially beneficial intervention. What do we think about training programs? Would this be a difficult training program to develop for respiratory therapists and then to demonstrate competency?
I think it would be relatively easy, to add some ultrasound component and the arterial catheterization. Again, you'd run into the same problems at the institutions where, just knowing from my experience as a program director and on the faculty for some 35 years, it's really more sometimes a political battle to get people to think that you should be doing invasive catheters and caring for them. I don't, in my knowledge, I don't think there's anywhere. I believe it's kind of regional, and when you get one place in, you can probably. I know, our friends in down there at Duke and that area of the country are a little more progressive than Pittsburgh area, Western Pennsylvania area, for example. But it certainly would not be a difficult training program. In fact, as I looked at that explanation of the training, I'm sure that should be standardized, and there should be a certain number that should be done under observation or on a mannequin. And then, although some of these new mannequins could also facilitate that as well, but it would be something that I think we should begin to think more about, especially the ultrasound component, if we want to move into this area.
Another question that was brought up was about defining the attempt. When we're looking at the study and we're reading the data and the authors discuss an attempt, are we discussing an attempt as in the needle is inserted and then withdrawn, the full cycle of the insertion withdrawal, or is a redirect? We don't get the blood, we redirect, we leave the needle in the arm, and then we find that vessel again. Is that a separate attempt? Do you think that this is all bundled, or are we just talking semantics at this point?
Well, no, that's actually a very good question, I think. Typically in research, that type of thing should be defined. I did not see a single article where they had a what would be termed an operational definition for what an attempt is. I suspect that it was withdrawal, penetration of the needle, and then withdrawal, even with some redirect. But that actually is a very good question. I didn't even think of that. But it should be defined. That should be something that should be defined in future studies. That would be a strong recommendation and a very good point, whoever brought that up. So
in a different, kind of related to attempts, but in a different vein, when we're talking about initial attempt success rates and successive attempt success rates, why would we be surprised if the second attempt rate would be as high as an initial attempt rate? Does that make sense?
Yeah, I guess in the article that we researched or looked at, they said importantly, and I kept thinking that same question, and the only conclusion that I came to was that it kind of showed that it really almost was the operator error, if you will, if you didn't get it in the first attempt, and that because if there was no pre-existing condition which made it more difficult, you would think that would still be there on the second attempt. So my logic was just that, and they used the term importantly, and I tried to think about that myself, and that's the best that I was able to come up with, that the fact that there was no condition of the patient that actually made it more difficult. It was just the fact that, I guess, the technique of the operator, is the reason why it wasn't inserted on the first attempt. Because, as I said, they even inserted those two in the patients with no blood pressure whatsoever. So, but that's a good question, and it's the reason I brought that up was because of their language there, and I thought that's the only thing that I could come up with regarding that point.
And then I think one more question that we have time for. So this one just came through, and this is a little more related to our pathophysiology. If our patient is already receiving vasopressor support, do you think it's more difficult to see the vessel with the ultrasound?
Oh, I would think so, certainly, because just due to size, it would just. But I think they're pretty good. Again, going back to the point, if you can get it in a vessel where there's no blood pressure whatsoever. Although I don't know. That's a good question. I guess I suspect that the vasopressor would make it if you will, a little more difficult target. But still, it should be able to be done. It seems as though you can always recognize, and I can't, unfortunately, speak from experience, but it seems that you can always visualize, if you get pretty good at it, the arterial, the radial artery. So it's really a matter of visualization and dexterity and holding the probe so it's not moving and hitting the target.
Well, Bill, thank you again for joining us today.
It was my honor, and I'd like to thank you, Shauna, and I think these are a good idea, and Reagan was very helpful, and I think these are very good things because people now, especially I notice students in particular, people who just get the online version sometimes get away from looking at research in as much detail. Just because, you get that magazine. I still get the hard copy myself because I love, seeing it come in the mail. It's a little present for me to look at.
Well, thanks again. And for those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.